Dear friends, today we are going to discuss about primary ciliary dyskinesia. It is a rare disease, but cilia plays a very important role even from the embryonic period. The defective cilia is responsible for the organ laterality, like situs inversus and heterotaxy and so on. In primary ciliary dyskinesia, the cilia become abnormal. The motility is abnormal, especially in the respiratory system, that is airway, nose, and middle ear, and also in the reproductive system. And we get a lot of symptoms. That is what we are going to discuss. PCD is a genetic disease. It is transmitted in an autosomal recessive fashion. That means both the parents should be carriers, and it typically present with wet cough from the early days of life, and some of the children develop neonatal respiratory distress, and over the years they develop frequent respiratory RRI, respiratory infections, rhinosinusitis, hearing impairment, and over the years they develop bronchiectasis if they are not properly treated. And in adolescence they may present with even infertility, particularly in female, because the fallopian tubes, the movement of oocyte or zygote, your ciliary movement is very, very important. That's why these people may go for infertility. Look at the prevalence. When compared to cystic fibrosis, it is really a rare disease. It is reported 1 in 20,000 in North America, whereas in same place cystic fibrosis is somewhere 1 in 5,000. But still this field is expanding because there are a lot of genes are implicated with PCD. Actually, cystic fibrosis is a single gene defect, whereas in PCD there are till today 50 genes are implicated with the PCD, and this field is expanding. Upper airway is an interface between the environment and the body. Actually, during our breathing, every day we breathe 20,000 liters, that is 5 gallons of air. Naturally, the environmental air is having a lot of particles, both infectious particles and non-infectious particles. And naturally, you should have a powerful defense system that has been grouped as, even from the nasal passages plays a role, and physical barriers. There comes your mucociliary clearance. That's what we are going to discuss. And a lot of immune system and reflex responses are responsible to clear the pathogens from the upper airway. What they say, we inhale roughly 1 million bacteria per day. So if all the bacteria go inside the body, every day you may develop pneumonia. That is the reason why the nature has given powerful defense, both immunological and non-immunological mechanisms. You go through that. So cilia is part of the mucociliary clearance mechanism. Actually, look at that. This is one yellow. This is a mucus. This is a cilia, and the mucus is present as an inner soul and outer gel layer. Actually, the outer gel layer is the one. This is the one that trap the particles, particularly bacteria, viruses, allergens, and actually it move over the sol layer. For that, your ciliary movement is very, very important. The ciliary movement, in the sense, the coordinated ciliary movement is very important. That is what not there in PCD. Actually, the cilia in the sol layer just bend and give a powerful stroke forward, and thereby pushing this gel layer towards the throat. and whatever that mucus contains, the infectious particles or non-infectious allergens that either coughed out or in small children it has been swallowed. Actually, this is a cut section of the cilia. Look at the cilia, and if you cut it, it's have this sort of arrangement. That is, in outside, it is a 9+10 arrangement. What they say that, and 9 peripheral doublets and 1 central doublet, and these are the in the outer doublets. You can see a hook-like structure. This is called dyninum. Okay, this is outer dyninum. This is inner dyninum. Okay. Actually, dyninum is very important. Actually, this dyninum is the one that converts your chemical energy, that is ATP, into mechanical energy, and that is responsible for the coordinated movements of the cilia. And actually, I already said cilia is not only present in the respiratory epithelium. We have been discussing these are the problem associated with the respiratory, but it also present in the eustachian tube, causing recurrent otitis media. It is also present in the ependymals of the ventricles of the brain. That's the reason why some children may develop even hydrocephalus. And it is also present in the fallopian tubes, movement of the zygote. And cilia is also a part of your sperm. So that is the reason why it is not a very simple. Actually, if you go into the see what we are actually, cilia is again discussed into motile and non-motile cilia. That I will show that. Why I am showing this slide is that a lot of syndromic ciliopathies also, PCD may be a part of that. Okay, and look at the cilia. Actually, this why I am showing this very important slide means cilia. I said from the embryonic life divided into motile, non-motile. Actually, the motile cilia is the one that is responsible for movement of clearance of the mucus and fluid, especially in the airways, reproductive system, sperm, brain and all, because of the planar motion. Actually, this rotatory movement, cilia has arrangement of 9+0, whereas this cilia or PCD cilia is 9+2. This 9+ rotatory. Actually, embryonic cilia is presenting the 9+0, and that is responsible for the your embryonic development. That leads to organ laterality defects. If this is going to be the nodal cilia is become defective. And again, one more cilia, non-motile cilia. Look at the structure. Here there is no 9 dyninums, no central doublets. These are all present in the kidney, bile duct, pancreatic duct, bone, eye. See, they also plays a very important role. Some don't confuse. Cilia is a very big topic. Now we are confined to only your cilia, motile cilia, that is presenting in these areas. So the most important question is how to diagnose PCD. Okay. Sometime before, we all thought this transmission electron microscopy was a gold standard test, because when it was introduced, everybody talks we can detect all the ciliary problems with this test. But after scientific study shows that it also misses 30%. So at present there is no gold standard test. Okay, so you have to concentrate the clinical presentation. Typically, it may present. Only thing is you have to spend time getting a very good history. And I am going to tell about the importance of nitric oxide, because it's a very simple test and it helps as a screening test in the diagnosis of PCD. We are also going to discuss about high-speed video microscopy analysis. Actually, in some parts of the world, in European countries and all, actually there is a lot of PCD centers are there. So they are all equipped with, there is a physicians or doctors have been trained with how to see the PCD, ciliary pattern, ciliary beat and all. Transmission electron microscopy, I think, is very important in the field of PCD diagnosis. We are going to discuss. Naturally, your genetic studies, particularly the exome sequencing, also become very important nowadays. And immunofluorescence is we are going to take. It is also contributing to the PCD diagnosis. I already said you should, any parents say my child is having a cough, chronic cough, that also wet cough. See, sometimes in the clinical practice we divide cough into dry cough and wet cough. Whenever any child have a chesty cough, wet cough, something there in the plum is there in the chest, you have to be very careful. And these are the children typically present with a neonatal respiratory distress, and over the years they may develop runny nose, sinusitis, and otitis media. These are all I said. Actually, one of the studies shows that the diagnosis of PCD is delayed. 70% of the patient see more than 50 times doctor before the PCD diagnosis was made. Actually, another paper also says that it takes at least 6 years, or even they're changing 6 doctors make a diagnosis of it. It's not very easy. Even though we are picturizing it a little easy way, it's very difficult. So your mind should know when the child is presenting with a wet cough, am I missing PCD and all. Actually, Picator score is also a very simple one. In tertiary places, probably doctors may practice in a little far away from the medical college, hospital, or PCD centers. Actually, you ask these simple 7 questions. Is it a full term or preterm? It is not happening in the preterm. So, if child should be a term, that gives 2 marks. Then is the child is presenting with a typical respiratory problem since their early life, that also gives 2 marks. Does the child have situs abnormality, situs inversus? And some of the children will also have heterotaxy, situs ambiguous also. It's a very small percentage, I'm telling. And perineal rhinitis, that gives another 1 mark. And if you put together any child will have more than 5, you have to strongly suspect. But the most important thing is the child should have a wet cough from the early days of life. This is another important test that is called nasal nitric oxide. There are 2 nitric oxide we are going to discuss. What I am talking is nasal nitric oxide. Actually, the nitric oxide production in the upper airway is much more than lower airway. They say that 100 times more than lower airway. And the normal level is given around 250. Actually, in PCD, it typically less. It comes to nearly 77 or so. And it can be possible, you can do this test, and you go through the videos, and you have to measure the nitric oxide from the nasal cavity, not in the oral area. So they have to block the palatal block should be there. And it's also diminished in cilia. I think that is the reason why whenever there is a nitric oxide is less, we have to rule out cystic fibrosis also. This is a very good slide. It's comparison between nasal nitric oxide and fractional exhaled nitric oxide. Actually, both are tests based upon the nitric oxide is a biomarker. I already covered the use of nasal nitric oxide, but remember FeNO. FeNO is also one of the non-invasive biomarker for asthma monitoring, not in the diagnosis, especially to predict the response. For example, the normal level should be less than 25. You are starting a ICS for an adolescent girl. She is also telling I am taking, but still she gets symptoms. Means if you do that FeNO, if it is very elevated, probably she has not, her complaints may be very poor. She may be telling lies. So in that way, monitoring is very important, FeNO. And also these days, many people in severe asthma, we use biologicals. There also FeNO plays a very important role. Nitric oxide, I think I purposely put this slide for the PG point of view, because nitric oxide is a very short-living gas in the body. It does many physiological and pathological functions. It acts as a signaling molecule to downstream many physiological process. And in endothelium, actually it is the one that causes the vasodilatation and reduces the BP. and it also plays a very important role. It acts as a retrograde neurotransmitter. So that is the reason why in nitric acid you should know everything about that, and it is simply body synthesis from the conversion of arginine to citrulline, and as it's a two-way process where nitric oxide is produced. It is a transient one, and since the airway if it go for inflammation, it increases. If the cilia, actually it is produced from the epithelium, cilia and all, so that is the reason why in PCD it is not at all produced, it becomes very very less. In that way, in inflammation it goes up. In PCD and cystic fibrosis is less, whereas in PCD it is very very less. In CF it may be less. There are some centers, PCD centers in the Europe as well as in the Western America. Actually they do this high speed video microscopy. Actually they use actually nasal brushing should be done. You take the cilia, then they utilize that high speed video camera and it captures the movement of cilia at the rate of 100 to 200 frames per second. In that way, a normal cilia should have a normal beat frequency and a beat pattern. So that is very abnormal. Actually, it's an experience dependent. It cannot be done. Actually, only the physicians or doctors who trained in this field, they can do it. But once you got trained, it's a very good, very simple test. You will take the nasal biopsy, then we can usually make a diagnosis. Today there are a lot of softwares are available. No need to spend the time, and you can frame that whatever you got it, that can be put it in the computer, and we can say whether it is a normal ciliary beat frequency or abnormal. In that way you can find out. Nasal brushing is actually taking the nasal cilia itself. Sometimes you can take the nasal cilia, or through the bronchoscopy you can also say the bronchial mucosa. Actually the cilia extends from the posterior 1/3 of the nose to the respiratory system. So you have to train yourself to take the nasal brushings. Actually I think it's without training you should not do that, because you cannot get the cilia properly. I think it may not be moving, but look at that the upper one is the normal. Actually the coordinated movement is such a way that it propels the mucus towards the throat. That is the way. I am not showing the video. You can go through the most of the in podcast you can see that. And this is abnormal one. Look at one cilia is this direction, the other cilia is this direction, this also like that. So this is a normal one, and second actually B and C is the abnormal one. So in PCD, that abnormal movement of the cilia, okay, is very important. Sometime before we thought it is immotile. That is the reason why the name has come as immotile cilia syndrome. After that, we all thought it is a coordinated movement is very very important. So you can see very nicely make a early diagnosis. Only thing is it has to be repeated to be seen by at least 2 physicians and all. And when transmission electron microscopy was introduced, I thought everybody it is a gold standard, because it is not going to miss PCD. But after that, some scientific study shows that even TEM, transmission electron microscopy, also misses at least 20 to 30%. So similar to the high speed video microscopy, here also we are taking the nasal brushings, and it is seen under the what they use a beam of electrons, and it forms a high resolution images, and you can typically see the structure, ultrastructure of the cilia, particularly the inner and outer dynein arms and microtubule organization and all. Look at that. This paper is one that has been, I think I given the references also. Look at this healthy one. Okay, central tubules, 9+2 arrangements. This can you see the dynamics? Dynamics 9+2 arrangement. This is normal. Actually, in the B is the one here that you cannot see the dynamics. This is what typically seen in PCD. Okay, you cannot see the dynamics here. The central tubule. Okay, some places it is absent. See, here is absent, central tube. Okay, here also it is absent. That is also one of the ultrastructural defect that goes with PCD. So like that, in a trained hand, the TEM is a very important place, and you have been seeing some of the slides. Can you see? Just go through that, which is normal. I don't want to go into the, just to see the outer doublets, inner doublets, and you also see the radial spokes, Nexin links. You also see that which is normal or which is abnormal. Can you see that? As most of the people would have been detected, this is a normal one. This is because both the dynamics are defective. Genetic analysis of PCD is expanding like anything. In 1999, when PCD was being diagnosed, hardly few mutations were implicated with PCD. Today, there are at least 50 genes that cause PCD. The common mutations that causing the dynamic defects are this one, DNA H5, DNA 1, and like that, the inner dynamic defects also is being implicated with. You can easily detect by the genetic studies. The field is experienced. That's what I said. Today 50 genes, and within another 5 years you may get some more genes, genetic defects also. See this very good paper that is telling that what are the ultrastructural defect and how the genes have been connected. The microtubules are been implicated with some genes defect, and motile ciliogenesis, central complex, radial spokes been defective with these genes, outer dynamic, and here Nexin links. See this also. See there are all so many papers. I think these are the days of AI. So even a single paper can be incorporated into the AI, and tomorrow AI is going to give you a correct thing. What is the one very common? Is it a outer dynamic defect, inner dynamic, or central Nexin links, like that and all? Actually, both CF and PCD are typically starts from the early days of life, typically presenting with a cough, wet cough, productive cough, and there is it is all both are autosomal recessive disorders. Only thing is, cystic fibrosis is one occur in the single gene, and a single gene. This is a very important one. Whereas in primary ciliary dyskinesia, more than 50 genes are implicated with the disorder. Okay, this is very, very important. So cystic fibrosis is a single gene disorder, and even that also is a problem. And here many genes. I already discussed how. I think any child presenting with a wet cough with a malabsorption, probably you have to go into this direction. Whereas any child presenting with a wet cough, the stormy neonatal period with a heterotaxy or situs inversus, then you have to go this direction. This another field, what they say, immunofluorescence. They use fluorescent antibodies to detect ciliary proteins. Actually, the cilia is made up of around 500 to 1000 proteins. So, simply, this is a very simple test. It appears to be very simple. We have to simply use the fluorescent antibodies. These antibodies is go and see whether this particular antigen is there or directive. In that way, it also helps in the PCD diagnosis. This is a one child. I very, very quickly see that I am going to say only two child. This is a 4-year-old term baby, chronic cough since birth, and consanguineous parents, pneumonia 2 times, otitis media, rhinorrhea, everything is fit into that. Look at the very stormy neonatal period. Child has been ventilated, stayed in the hospital for 24 days, even there is a tiny VSD and all. After that, the child is also didn't follow, actually with this background, what all you think is a recurrent respiratory infection or recurrent pneumonia. So whenever there is a recurrent respiratory infection since birth or even recurrent pneumonia, you have to think of these hereditary disorders like cystic fibrosis, ciliary dyskinesia, immunodeficiency. These are all we have to rule out. Some of the anatomical disorders like aspiration syndrome, escape of fistula, you have to think. And there are some rare disorders of immunity also you have to keep in your mind. So this child is one very typically we are worked out because the sweat chloride was normal, so cystic fibrosis is ruled out. Then flow cytometry and immunoglobulins are normal, so it's not immunodeficiency. And I done a bronchoscopy also, the bronchoscopy is normal. So left out is primary ciliary dyskinesia. So the child was subjected for nasal nitric oxide, and the nasal nitric oxide is very very low, less than 70. So it is a screening test as positive. Then the child is subjected for genetic study. That is, we have done, we have not done whole genome sequencing. We have done only exome sequencing, clinical exome sequencing. Actually, clinical exome sequencing is less cost because it is going to screen only the exons, 1 to 2% of the genome, and we are able to detect a mutation, dynomes. So this child has been named as PCD. Now we are following the child, and we explain the parents the importance of treating the infection, because the infection may be frequently occur. We have to promptly treat the infections, okay, and also to give the vaccines. Sometimes the child needs a clearance and all, we explain. So how we detect it means this is clinical history, and even X-rays are normal with the situs altus. There is no situs inversus, and we done a sweat chloride is normal, flow cytometry normal. Nasal nitric oxide is the one that helps us, because with this clinical background the nasal nitrics are very very low. Then genetic studies has confirmed there is a PCD. This is another child. Actually the child has been referred from a very long distance. Actually the child has been suffering from the last 5 years, 5 to 6, I think. Wet cough, the child's situs inversus. This is one of the X-rays, but some of the X-rays showing even bronchiectasis. I showed only one X-ray, and the child has been treated as a pneumonia, asthma, repeated nebulization. Actually, when they come to us, we done a mutational study. It is positive, PCD positive. Okay. Actually, this child is classically fit in because the child has a situs inversus, sinusitis, bronchiectasis. It's called cartogenous syndrome. PCD, sometime before, initially it has been called immotile cilia syndrome, because we all thought the cilia is immotile, not moving at all. Later only we came to know that it is abnormal movement of the cilia is responsible for your ciliary. That is the reason why name is changed from immotile to PCD. These are some old books will say dyskinetic cilia, ciliary motility disorder. Don't confuse. Now we have to use only the word PCD. Okay. And I think whenever it's something like the same cystic fibrosis, here ciliary dysfunction, impaired mucociliary clearance is a very important mucus stagnation that leads to inflammation or infection, bronchiectasis. Okay, so airway clearance is very very important, and actually airway clearance therapy that is you can go for some physical techniques or some pharmacological mucoactive agents and all. And so airway clearance therapy can be broadly classified as chest physiotherapy, that includes postural drainage, percussion, active cycle of breathing, PEP devices. In the mucoactive agents also many things, of which the most important thing is the hypertonic saline, beta agonist, and of late some people say N-acetylcysteine also is very useful and all. In my experience, I think when a child develops bronchiectasis, I am telling either a PCD or cystic fibrosis, if they start developing bronchiectasis, you have to put the child on postural drainage. Your drainage should be such a way that your lower head should be elevated, because the upper lobes are always drained from above downwards. It is only the middle lobe or lingula drain from down to up, and even the lower lobes are draining from down top. That is the reason why when these children go for any problem with the lingula or right middle lobe or lower lobes, you have to put postural drainage. Lower lobe means 18 inches elevation, whereas the middle lobe 14 inches. I think hypertonic saline sometimes works well because it also makes the sputum less viscous. Over the period, either in the cystic fibrosis or in the even PCD or any other chronic suppurative disease, the mucus become very, very stagnated, thick. So you have to, it is not easily expected. That is the reason why we are using 3% tonic saline, and it also helps to have some protecting the structural changes also. N-acetylcysteine, actually it works in a different way. It breaks the sulfhydryl bonds of the mucus. When a child is presenting with a huge mucus stagnation and you are not able to do anything, go for this one alternating with hypertonic saline. And it also some other indications. It also acts as an antioxidant. It should not be given for around the clock. These are the N-acetylcysteine and all. It can be given along with the salbutamol inhalation or alternatively with the hypertonic saline, 3% hypertonic saline and all. Lot of mucoactive agents are studied both in the PCD as well as in the cystic fibrosis. I think to my knowledge still hypertonic saline and even salbutamol nebulization or N-acetylcysteine or do some better work. And coming to the rehabilitation, I think these children, there are a lot of instruments are available, and you can also advise to use a cappella, because a cappella is the one, it can be used in all the positions, whether you are sitting, standing and all, unlike the flutter valve. So actually these PEP devices develops, here the child blows against the resistance which creates a positive pressure causing the ball to vibrate. Thereby it acts as a clearing, it propels the mucus forwards. Another small, very simple, in older children we always ask them to go for a ACB, active cycle of breathing. Actually here it's a very simple technique. Go through the, initially the child should have a normal relaxed breathing. Normally slow breathe through the nose and slow breathe out. Breathe in through the nose and breathe out through the mouth. After that some deep breathing, and then we have to hold for at least 5 to 10 seconds. Then it is followed by a half like that. Thereby these combined procedure, relaxed breathing, deep breathing and ups, make them to clear the mucus, and it also acts as a mucoclearance mechanism. I think this is the last slide. People may be listening me, and I want a simple question. Don't take this an exam. You've been listening me my lecture with relevance to PCD. Which of the following is the least common? My question is not the most common, least common. You take 1 or 2 seconds, quickly you answer yourself, you put a mark. Whether it is a chronic wet cough is the least common, sinus inverse is the least common, or respiratory distress, otitis media is least common, or and anybody, if they put of all these things, situs inverse is the least common. Okay, many people thought situs inverse may be the most common. That's not so. Actually, study shows that wet cough is the one that typically present from the early date of life, and that is around 100%, whereas situs inverse only 50%. That's the reason why I put this question. And any child presenting with a very stormy neonatal period, wet cough, or some otitis media requiring or any sign of typically recurrent sign of pulmonary infections, we have to think of PCD. I think this is the last slide. Thank you. I think I want to salute all the researchers. They have done excellent work on this field, and they have been continuously doing and all. And all my references goes with this and all. Thank you. I'll see you on sometime later and all. Okay. Thank you very much. Thank you very much. Okay.